Well, hello, everybody. I'm David Rubin. I'm in Chicago, and I'm really excited about this symposium that I'm doing with my good friend, Millie Long. This is a program called Pursuing a Gut Feeling, Exploring Immune Cell Trafficking Inhibitors to Treat IBD. So we're moving into a new class of therapies, and we also have some existing therapies that approach this same topic. This activity is provided by IMEDX, which is an HMP global company. Our educational partner is Vindico, and we're very grateful for their CME assistance and their content assistance in pulling this together and thinking about how we can educate each other the best way possible. And it is supported by an unrestricted educational grant from Genentech, so we're grateful to them. As I mentioned, I'm David Rubin from the University of Chicago, and joining me is one of the AIBD co-directors, Millie Long, who, as you see, is an associate professor of medicine, as well as the director of the GI and Hepatology Fellowship Program, vice chief for education at the University of North Carolina at Chapel Hill. And I always love doing programs with Millie, not just because we often are similar in our approaches, but I always learn something from her as well. I'm starting our agenda off talking about IBD pathogenesis and how we've been thinking about targeting inflammation in different ways. And then Millie will be teaching us a bit more about modulating immune cell trafficking and some of the data to support how we can block invasion of inflammatory cells to treat IBD. So let me kick it off now by talking to you a bit about IBD pathogenesis. We've been seeing similar slides about this topic for a long time, but I'm going to do my best to pull this together in some new ways and give you some practical pearls for your own practice, as well as where we're thinking and trying to go as a field. I do have some disclosures that are, of course, relevant to any discussion about therapies in IBD, but as I've mentioned, this is a CME program, and these are slides that were developed for that purpose, and of course, I stand by all of my own comments. So for a long time, we've been seeing a Venn diagram about the pathogenesis of IBD, outlining the different contributing features to the development of the chronic inflammatory conditions we call Crohn's disease and ulcerative colitis, representing what we think is a genetic predisposition or susceptibility, some environmental factors that trigger an immune activation, which is dysregulated or loses its ability to control itself. Now, in the process of coming to appreciate all this, we also include the microbiome, or at least microbes in some degree, in all of this. Now, arguably, microbes can also be considered part of the environmental factors. So you can imagine putting them underneath environmental factors and then thinking about how they may be triggering the immune activity and the ongoing either constitutive stimulation of the immune activity or the loss of regulation. And there are different theories about what might be going on and why this might occur. One of the main messages about the pathogenesis of inflammatory bowel disease, though, is that it clearly is very heterogeneous. And I emphasize to patients, and I want to emphasize today, that individual patients have individual contributing factors that lead to their specific version of inflammatory bowel disease. I personally believe that one of the major advances and changes in our field will be in the reclassification of IBD in a meaningful way that will change our interpretation of prognosis. And of course, we definitely need some way to predict who's going to respond to which therapies. There's been some incredible work done in the genetics of inflammatory bowel disease. Some people have called this the genetic gold rush in IBD, which led to the identification of more than 200, and I think we're actually up to over 300 loci of single nucleotide polymorphisms that are associated with both Crohn's disease and ulcerative colitis. The purpose for this slide is not to get into all of the details regarding those, but to demonstrate to you that as these different associations have been identified, and with advancing technologies, we've identified more and more, and some of them have quite significant statistical associations, we've also been able to see that there's an overlap with other conditions. What you can see in this Venn diagram is, number one, there's a big overlap of these susceptibility genes or these associated loci between Crohn's and colitis. But secondly, a number of these have been previously identified related to pathways that increase susceptibility to specific infectious disorders or other immune-mediated conditions. It's not a surprise to think that, since we believe that part of what triggers IBD in some patients, maybe infectious related, and also certainly not a surprise to understand that variants of these genes may cause other immune-mediated conditions. What we're desperately waiting for, however, is a way to use this information to understand better how to choose therapies or even to provide cures for our patients. We're not quite there yet, unfortunately. There's also been quite a bit of work on environmental factors in IBD. Since we're seeing a rise of IBD around the world, the question hasn't been whether the human genome has changed, but of course, what in the environment has changed that may be triggering IBD. And there are a variety of different association studies that have their own limitations, but suggest some correlations related to the development of Crohn's disease and ulcerative colitis, or conversely, being protective against Crohn's disease and ulcerative colitis. And I've highlighted a few of them here in this nice slide that I borrowed from our friend Maria Abreu. And of course, you know about the association between smoking cigarettes and the development of Crohn's, or quitting smoking and developing ulcerative colitis. That's a very strong association that's been described. But these other ones are of great interest to us as well, and I think provide clues as to what might be going on in some of our patients. Looking at these two arrows, you can appreciate the things that increase the risk of both Crohn's and colitis, including oral contraceptives, which have been associated in some studies, prior GI infections, and of course, we've all seen a patient who had a GI infection or maybe traveler's diarrhea and then developed IBD, diets that are high in carbohydrates and fats, living in urban environments and potentially pollution related to that, exposure to antibiotics in childhood has been associated definitely with the subsequent onset of Crohn's disease, but also in some studies with the onset of ulcerative colitis. And patients always tell us that stress is related to the onset of their disease, although those studies are very difficult to perform and sort of mixed in their results. We also have seen that patients who have diets high in linoleic acid are more likely to develop ulcerative colitis. Things that lower the risk, of course, is having adequate or even supra-adequate levels of serum vitamin D. High fiber diets have been associated with reduced risk, although you can argue about causation and correlation. H. pylori, very interestingly, and conversely, eradication of H. pylori, maybe because of exposure to antibiotics, has been associated with the rise of IBD, and helminth infections, going along with that old hygiene hypothesis and the innate immune system. Now we're going to get into a little more detail, and I want to just emphasize that we've certainly learned a great deal about how the genetics of our immune system interacts with the environment to protect us. On the left side of this slide represents what it looks like in somebody who has healthy mucosa, while on the right side is a patient who develops the chronic inflammation of IBD. And I want to emphasize that there are the commensal bacteria that in a healthy individual are diverse and include more firmicutes and Bacteroidetes, as well as diminished or decreased amounts of Enterobacteriaceae, as well as increased Faecalibacterium and Rosaburia. If you look all the way to the right side of the screen in those who have what they call dysbiosis, which is variously defined, one of the features to keep in mind is that the microbiota of people with IBD has reduced diversity, increased Enterobacteriaceae, including E. coli of the adherent and invasive strains, increase of the Ruminococcus, and decreased Clostridium groups 4 and 14A. So we've learned a little bit more about what happens. What we haven't learned, though, is whether that's a chicken or an egg. In other words, whether the disruption or imbalance of the microbiota is a result of the inflammatory process or somehow driving it. Now, in the subepithelial space, you can appreciate the complexity of the immune system. We're focused today thinking a bit more about understanding a number of different components of all of this, specifically the different selectins, cell adhesion molecules, chemokines, or integrins that are all related to how our body sends and recruits and activates the immune system to do its job. As I always mention to patients, the immune system of our intestines is there to protect us and to distinguish between what we need in terms of nutrition and what can harm or kill us in terms of infections. And therefore, that's why it's quite complex and why we need to have a robust response. And I try to educate patients as well that this is the system that's designed to protect you. It's just lost its ability to shut itself off, which is what causes the chronic changes. I want to emphasize that this is where a lot of our therapies have focused. You can scan your eyes across just to orient you. The top of the screen is the lumen of the gut. Then you have the epithelial cell lining of the gut with a crypt on the left there, going all the way down to the left side. And then you can appreciate the different components here, including a blood vessel, a lymph node, which is highlighted here, and then all the other components of the different T cells, the cytokines they secrete, as well as the intracellular activation through Janus kinase and the JAK-STAT pathway. We have therapies that are currently available and therapies that are in development that target some of these different pathways. And I'm not going to cover them all on this slide, except to point out to you that as many therapies as we have, there are still a number of components of this complex immune system that have not been adequately targeted yet, or certainly have not reached beyond the early phases of their clinical development. This pipeline slide shows you what we currently are focused on in phase 2 and in phase 3, and reminding you about what's already licensed for treatment of Crohn's and colitis. And you can appreciate the different classes of therapies. Millie and I are going to spend a little more time on the anti-lymphocyte trafficking agents and the newer class of therapy called the S1P receptor agonists. And you are familiar with the anti-cytokine therapies of anti-TNF, anti-IL-12/23, and coming soon, specific anti-IL-23 therapies, which are P19 inhibitors. And you're also familiar with the anti-integrin therapies that are currently available. We'll talk more about that. So our biological therapies for IBD now include 3 classes of therapies: the anti-TNFs across the top that you know well, the anti-integrins. Don't forget that natalizumab was available since 2008, and vedolizumab came in 2013. And then, of course, ustekinumab, which is actually an anti-P40 antibody. Targeting that P40 protein knocks off 2 cytokines, IL-12 and 23. I sometimes say that it's like hitting 2 birds with 1 stone. The stone is P40. Now let's talk a little bit more about adhesion molecules and how they work. So the idea here is that a chemoattractant source or some antigen can trigger an immune response. And what happens when that occurs is that the human body is quite remarkable, as you all know. It actually then triggers lymphocytes to migrate to the location of where that chemoattractant source may be located. And that may be from selectins, which are cell adhesion molecules. It may also be from chemokines, which are cytokines that trigger this reaction. And then the way the body's immune system knows where to go is based on the interaction between integrins on the surface of lymphocytes, and then the subsequent ligands that they bind to, which are unique to those integrins. Some of my colleagues have previously called integrins like zip codes. They basically tell the lymphocytes where to go so they can get where they need to go. And you may recall from medical school and maybe more recently about the way leukocytes migrate out of the blood vessels and into the extracellular space or into the subepithelial space or the lamina propria. And you can see the cartoon here of the lymphocyte rolling and then migrating between the endothelial cells. The anti-adhesion therapies for inflammatory bowel disease that have been developed and are in development are demonstrated on this slide. On the right is the therapy that was available first, which was natalizumab. This one was specifically targeting the integrins alpha-4 beta-7 and alpha-4 beta-1. And it was the alpha-4 beta-1 component that ended up causing it to be effective in the central nervous system, but also be associated with progressive multifocal leukoencephalopathy. Vedolizumab targets only alpha-4 beta-7, so it's considered to be selective against that component of our immune system, which is primarily in the intestinal tract. And in development is Atrolizumab, which is an anti-beta-7 therapy that Millie will talk more about, which targets the beta-7 as it's bound to 2 different cytokine collections. And then there are some therapies that were in development targeting adresins, a different component of all this, but with the exact same principled mechanism, which were the Antimadcamp therapies. One of them is on hold and others are in earlier phase development. Another way to try to explain this all to you is to look at this cartoon, which summarizes the different targets here. So you see Eternalism in the middle, the drug you're most familiar with, which is anti-alpha-4 beta-7. And then you can appreciate Atrolizumab there, which is the anti-beta-7, which is an alpha-E as well as alpha-4. So it has a couple different targets there and works on two different ligands. And then Natalizumab, which is, as I mentioned, against the ligand of VCAM. So the MADCAM one is the most selective for the gut, although there is some benefit to the ecahedron that I'll emphasize in a moment. Now, what do we know about Eternalism and how gut selective it really is? This is one of my favorite studies in which they actually looked at whether or not you could mount an immune response with an oral antigen vaccine, the oral cholera vaccine. So if you look on the right, you can see that patients who had received Eternalism in its effort to reduce the lymphocyte trafficking to the intestines did not mount an immune response to oral cholera, while those who received placebo did. And on the left, getting an intramuscular injection of the vaccine for hepatitis B was effective whether you had Veto on board or not. So if you rely on the intestinal system to expose you to antigens to develop immunity, it will be inhibited when you use a gut-selective drug that blocks leukocyte trafficking or perhaps even blocks other mechanisms that are related to that MADCAM system. Very interesting and important. There are some potential implications for how this might weigh in on the vaccines against SARS-CoV-2, and we can maybe think about that later. Now, looking at Atrolizumab, I already mentioned to you about how it targets beta-7, therefore it hits alpha-E and alpha-4. And I just want to emphasize that it's believed that this means it has two different mechanisms of action. On the one hand, similar to Eternalism, it blocks lymphocyte trafficking. On the other hand, it may also promote egress of cells that are already there and pulling them away, which is what the ecahedron ligand may be doing for it. So very interesting concept to consider, and we'll see whether that translates into efficacy in the clinical trials when Millie summarizes some of that for us today. And then lastly, and most recently, is our interest in the S1P receptor modulator therapies. S1P has a gradient across lymph nodes, and therefore, depending on which S1P you block, you can actually have an effect of preventing the egress of activated lymphocytes from lymph nodes. So you are essentially also shutting down a cellular trafficking system, but in a different way. And it's very interesting to understand how this may work. And there's now a couple different agents that are in development, and Millie will touch on those as well. And remember as well that ozanimod is an S1P agent that is now available in the US market for relapsing multiple sclerosis. This is a summary of some of the S1P inhibitors. There are a couple others, including etrasimod, that are worth mentioning. And I just wanted to point out to you some slight differences in all of these. Ozanimod does not require phosphorylation in vivo to become activated. There's a short onset of action with time to lymphocyte count reduction measured in hours, as well as the decrease from baseline significantly reduced, which is something that we think leads to direct efficacy. So quite an interesting class of therapies. And because these are small molecules and not monoclonal antibodies, they are orally delivered with a predictable PK profile in the small intestine. So just keep in mind that trafficking inhibitors in IBD clearly have a role. We already have available to us our monoclonal antibodies of Natalizumab and Eternalism, and we're excited about the opportunity with newer therapies that are coming, specifically the S1P receptor agonist therapies. So with that, I'm going to take a little break and let Millie teach us a little more about modulating the immune cell trafficking and looking at some of the available data.
Wonderful, David. Thank you so much for setting this up so clearly in terms of trying to better understand immune cell trafficking and blocking the invasion of inflammatory cells. You know, I think that mechanistic description really helps us to understand where some of these novel agents may fit in our armamentarium for the management of inflammatory bowel disease. So I do have a few disclosures to mention as well. And with that, I'd like to move into a case that I'd like to frame this discussion with. And one of the hats I wear in my clinical practices is that I'm also a clinical trialist, and I do enroll patients in some of these earlier term clinical trials. And I always like to think about who are the right patients for those situations. And so this is a patient of mine, a 67-year-old gentleman who had a 12-year history of UC, and he presented with basically worsening symptoms. At diagnosis, he had failed sulfasalazine and topical 5-ASA, required prednisone, and really had done brilliantly on infliximab for induction and maintenance for a time period of about 10 years. And actually, at that point, he started to develop new onset neurological symptoms. And so I very quickly pursued an MRI of his brain, and he actually had paradoxical demyelination. And this was thought to be associated with the anti-TNF. And I've seen a handful of these cases in my own practice over the years. And so clearly at this point, we stopped the TNF. He'd been in endoscopic remission for some time. So I actually just maintained him on mesalamine. But unfortunately, he started to have increasing symptoms, as I mentioned, and his flexible sigmoidoscopy did demonstrate active inflammation, Mayo 2. And so this is a gentleman who really has a contraindication to at least anti-TNFs in terms of the current available classes. And I talked to him about clinical trials because in this scenario, based on the mechanistic description that David just provided, something like a gut-specific leukocyte trafficking agent would be ideal because it wouldn't necessarily affect his brain. Another option that could be ideal would be something like an S1P that David mentioned is already approved in MS. And so thinking this through, I thought this could be a good opportunity for him. And so now what I'd like to do is review some of the data surrounding modulating immune cell trafficking. We'll talk about the safety and efficacy of currently available immune cell trafficking agents, so Natalizumab and Vedolizumab that David mentioned, as well as safety and efficacy of anti-integrin agents under investigation. We'll then touch on S1P inhibitors and then wrap up with a little bit on clinical trials participation in our case wrap-up. And so let me start with Natalizumab and Vedolizumab. And so, frankly, for many years, I actually still had a few patients with Crohn's disease on Natalizumab in my practice, but actually I don't anymore. And I'll share with you some of the reasons why. This was probably the most recent data we have on Natalizumab, which was a Cochrane review that looked at 5 randomized controlled trials of Natalizumab versus placebo for Crohn's disease. And the primary outcome was a failure to enter clinical remission. Secondary outcomes, they looked at AEs, and most of those included things like headache, nausea, nasopharyngitis, the things we see most commonly with our agents. And they found that Natalizumab is effective for induction of clinical remission in moderate to severe Crohn's disease, but none of the initial RCTs had the power to detect a rare complication like PML that we now know is associated with Natalizumab. So due to this association with PML, progressive multifocal leukoencephalopathy, and available alternate agents, Natalizumab is not likely to be used in Crohn's disease populations other than in select rare scenarios. And those select rare scenarios may be in a situation where a patient has concurrent MS and their anti-JC virus is actually negative. When you look at the data, again, failure to enter remission at week 12, Natalizumab is better as compared to placebo. And really early on, there were very few PML cases, but even by 2017, there were over 700 confirmed cases of PML, and this is really a fatal condition. And so I really have taken this drug out of my armamentarium now that we do have other agents like Vedolizumab in our arsenal. And so Vedolizumab, let me just quickly review the data for induction and maintenance in the Gemini trials. On the left, you will see clinical response, middle clinical remission, and on the right, mucosal healing. The left shows induction, and the right shows the maintenance phase, where clearly we have a separation from placebo with a delta for clinical remission of about 12% for induction, and even higher for mucosal healing. And in the maintenance phase, we're reaching rates of corticosteroid-free clinical remission of about 31%, again, showing the efficacy of this agent. When we look at the Gemini 2 data, again, this is in Crohn's disease, whereas previously I was showing you ulcerative colitis. The week 6 induction results, at this point, in terms of response, we did not necessarily see a statistically significant difference, but a difference with clinical remission. And then week 52 maintenance results, again, you're seeing these numbers around 30%, and that you'll see fairly frequently throughout these presentations, but definitely a difference as compared to placebo in terms of maintenance of clinical clinical remission amongst responders to vedolizumab at induction in Crohn's disease. However, I do want to point out that this was a really sick population. 60% had prior anti-TNF failure, about a third had 2 or more prior TNFs, nearly half with prior Crohn's disease surgery, and over a third with prior fistulizing disease. And so again, in a complicated population, this drug has demonstrated efficacy. In the Gemini 3 study, when we looked specifically at anti-TNF failure populations, which is over on the right, you will see that what I kind of describe is that while we do see effectiveness, particularly at week 10, where you see a separation as compared to placebo, it may be a little bit slower in patients who are anti-TNF exposed. And clearly in anti-TNF exposed patients, as we see with all of the biologics brought to market thus far, we have not seen as robust response and remission rates as compared to the naive populations. But again, a rate of 26.6% as compared to a 12% placebo rate at week 10. The long-term safety of vedolizumab has really been very reassuring. This drug has been on the market now for 6 years. We have long-term data from the Gemini trials as well as real-world experience that really have demonstrated a robust safety signal. 6 studies with follow-up of up to 5 years of nearly 3,000 patients. You'll see that rates of any infection were actually quite low, serious infection markedly low. In the whole history of vedolizumab, there's been 1 case of PML, but this was not attributed to vedolizumab. It was an HIV-positive patient who was on concurrent immunosuppression, and so it was attributed to that. And so we can clearly tell our patients that the signal that we saw with natalizumab is just not there for vedolizumab. Infusion-related reactions were infrequent and really exceedingly low rates of malignancy. So this drug has really proven excellent from safety perspective. From a clinical experience perspective in real-world populations, the Victory Consortium has actually taught us a great deal. And even considering the fact that there were patients waiting in the wings when this drug was approved, such that it was really quite a severe population when we first initiated vedolizumab, the efficacy rates were actually fairly comparable to what was seen in the Gemini clinical trials. And so in this consortium, they looked at 12 months cumulative rates of clinical remission, which were 35%, mucosal healing, 63%, and deep remission at 26%. When they looked at predictors of non-response, it was prior TNF exposure, as I'd mentioned, smoking history, active perianal disease, and having more severe disease, which all makes some sense in terms of reduction of response. And in their safety data, the duration of follow-up was 160 patient years and very low rates of infusion reactions, serious infections, or serious adverse events, in spite of this being a quite severe patient population. And so I want to emphasize that while this drug has been on the market for some time, we actually will likely soon have a new formulation of vedolizumab. And so recently the VISIBLE studies have been presented and actually published. The VISIBLE trials looked at SubQ vedolizumab, which is effective after IV induction in UC. These are data showing clinical remission at week 52 on the left, placebo, with SubQ in the orange, and in the green is IV, where clearly you see a large delta as compared to placebo, and really no difference amongst the IV or SubQ populations. And on the right-hand panel, you'll see that the Gemini data, this was from the original trial with the IV induction and maintenance. And again, you see very comparable rates to what we saw in the VISIBLE trial looking at SubQ versus IV. So this is a really reassuring signal that for appropriate patients, after an IV induction, at least in the trial, it was at least after 2 IV infusions, changing over to SubQ vedolizumab will be effective and comparable to the IV. And this really provides an option for many of our patients from a convenience perspective. VISIBLE also looked at Crohn's disease in the VISIBLE 2 trial. And again, this was a phase 3 randomized double-blind placebo-controlled trial. And when you look in the left-hand panel at the week 52 clinical endpoints, again, I'll have you focus on the third panel over with corticosteroid-free remission, where we do see vedolizumab SubQ more efficacious as compared to placebo. And overall clinical remission also met a statistically significant difference. We also had supportive evidence with reductions in fecal calprotectin and CRP normalization. And so, again, no new safety signals with this therapy, and it does look like maintenance therapy with SubQ vedolizumab is safe and efficacious for Crohn's disease and pretty consistent with the IV formulation in those who initially respond to that IV induction. So this hopefully will be in our armamentarium soon. There were some concerns initially about the potential for site reactions associated with the injection of this. But really, in these larger studies, including one recently presented at UEGW, we did not see high rates of site reactions. So I think that won't be a problem. So now let's move on to talk about other anti-integrin agents under investigation. And in particular, I'd like to start with etrolizumab. And so I'd just like to frame this discussion with the phase 2 results, which came out several years ago for etrolizumab in UC. Again, remember, this is the alpha-4 beta-7, but it also has the alpha-E beta-7 component as well. And on the left was all comers, where you did see a difference at week 10, comparing the etrolizumab as compared to placebo. And on the right, the TNF naive population, which really had a very robust response at week 10, here at 44%. And then all the way on the right, the TNF failure population, which here we did not see a significant difference. And so this study helped them to launch a very ambitious series of studies to look at etrolizumab in both ulcerative colitis and Crohn's disease. And they recently presented the series of ulcerative colitis results that I'll share with you. These were initially presented at UEGW. Just prior to UECW, we had this press release, which said that data from the pivotal UC trials really did not meet all of its endpoints. In fact, it met its primary endpoint of inducing remission versus placebo in only 2 of 3 studies. And in fact, it did not meet any of its primary endpoint in any of their maintenance trials. And that they are ongoing with phase 3 study of etrolizumab in Crohn's disease. And we look forward to those results. But I do want to dig into the results a little bit in regards to where we're seeing some of these differences. And so this is the Hickory trial, which looked at etrolizumab in an anti-TNF failure population. And on the left, you'll see clinical remission at week 14, an endpoint they did meet with the pale blue, 18.5% as compared to 6%. But when they looked at clinical remission at week 66, they did not have separation from placebo at that time. Secondary endpoints, interestingly, at week 66, they did meet. So there was a difference in endoscopic improvement, endoscopic remission, histologic remission, and steroid-free remission, which makes us think there is still a signal for efficacy with this drug, which, remember, a component of it is similar mechanism to what we see with vedolizumab, which is on the market, but yet, again, did not meet primary endpoint. Laurel was actually an interesting study design, which looked at etrolizumab versus placebo in anti-TNF naive patients. And this was open label induction, and the responders were randomized to etrolizumab or placebo for 52 weeks. Everyone got the drug up front, and there can be a long tail to some of these adhesion molecules. So it could be that even once they went on placebo, they could have had some benefit. The primary endpoint was clinical remission at week 62. And as you can see on the left, we really did not see a statistically significant difference there. When you looked at secondary endpoints on the right, particularly for histologic remission, endoscopic remission, and endoscopic improvement, we did see a difference. The next trial is Hibiscus 1 and 2, which was an induction trial. But then also there was an arm that looked at adalimumab as compared to etrolizumab. And so this was actually powered for superiority, meaning they weren't trying to just meet similar efficacy as adalimumab. They were actually trying for superiority. When you try for non-inferiority, you often need larger sample sizes. But they had 716 patients randomized. And only one of the 2 induction trials actually met the primary endpoint of remission. But when you look at the comparison of etrolizumab and adalimumab at week 10 on the right, you really don't see much of a difference in terms of these outcomes. Again, it wasn't powered for non-inferiority, but definitively we can say that etrolizumab is not superior to adalimumab in these scenarios. Gardenia was actually a trial design that looked at etrolizumab versus infliximab. And they had over nearly 400 patients with moderate to severe UC. And it was a population where almost a third were on steroids, 20% on immunosuppressants, 14% on both. So certainly a group that did have significant disease. And the primary endpoint was clinical response at week 10 and remission at week 54. Again, powered for superiority. And we really saw, as you can see in the left panel, no difference at week 10. And on the right panel, secondary outcomes also with no difference. Again, not inferiority designed, but we can say that there's no superiority of etrolizumab as compared to infliximab. And so that was a lot of data on etrolizumab. We need to dig into it and discuss why we think this may not have worked in several scenarios. But on the right is just a summary of results where what met its primary endpoint. And as you can see, really it was only 2 of the trials that met the endpoint for induction of remission. And really none of them met their maintenance endpoints. So again, we look forward to data in Crohn's disease with this compound, but at this point, a mixed bag with etrolizumab. Another agent, Brillomap, these are data from a phase 2 RCT versus placebo for moderate to severe UC, which was dose ranging. And as you can see on the left, with primary endpoint of remission rate, you see a separation from placebo, both in patients with anti-TNF failure as well as patients anti-TNF naive, particularly with the higher doses of this therapy. And for mucosal healing, a similar pattern on the right-hand panel. And so again, this product is moving forward in phase 3s, and we'll be interested to see whether we have this in the future on the market. AJM 300, another phase 2A study in moderate to severe ulcerative colitis of about 100 patients. And when you look at clinical response rate on the left, quite impressive as compared to placebo, clinical remission and mucosal healing on other panels, again, demonstrating that separation. And so this agent will be moving forward as well. The phase 2 Toronto data, this is Antimadcamp, where David showed you on the diagram, which may be the most specific inhibition. And it did demonstrate effectiveness in moderate to severe UC as well. There were higher remission rates in anti-TNF naive patients as compared to anti-TNF exposed, as we've seen with many other compounds. And then the highest remission rates were actually with the middle doses, the 22.5 and the 75 milligrams. And all doses showed a drop in fecal calprotectin, which is important. Placebo did not. Again, demonstrating that this has biologic plausibility in terms of inflammation reduction within the GI tract. So let me speak briefly on the S1P inhibitors and then wrap up our case with clinical trials participation. These are the phase 2 data associated with ozanimod and ulcerative colitis that were published a little while ago and demonstrate the efficacy of clinical remission at week 8 in the top left-hand panel of particularly the 1 milligram dose of ozanimod and mucosal healing, also with a significant difference on the left panel. And they really had robust definitions, standard definitions of clinical remission and mucosal healing with this study. They did evaluate histologic remission with a GBO score of less than 2 and also demonstrated separation. Similarly, they published the maintenance data. These are at week 32, where you see the separation actually for both doses, the 0.5 milligrams and the 1 milligrams. And so this did lead, obviously, to a phase 3 study. Importantly, one of the things they wanted to delineate going into the phase 3 study is the safety associated with these compounds. Particularly, one of the things that we have been somewhat concerned about is whether there may be some symptomatic bradycardia in these patients on this therapy and whether EKG testing may be needed. At least in this phase 2 data, this looked quite clean in terms of cardiac adverse events and a little bit of increase in ALT in this study as well, but overall demonstrated safety. And so this led to True North, which actually was just presented at UEGW. And this was a randomized controlled trial of ozanimod, almost about 430 patients as compared to placebo. And the primary endpoint was clinical remission at week 10, with secondary outcomes, as I've shown you, similar to other agents. And so on the far left of this graph, you'll see that clinical remission was significant as compared to placebo, with a clinical remission rate of 18% as compared to 6%. And it also met the other secondary outcomes, clinical response, endoscopic improvement, as well as mucosal healing. And just as we've seen with other agents, it really the results were more significant in the anti-TNF naive population. For maintenance, in that same group of responders who are randomized to maintenance with outcome at week 52, clinical remission on the left, 37% with ozanimod as compared to 18% in placebo, demonstrating a significant delta and actually a comparable rate to what we've seen with many other agents. And again, it did meet its secondary endpoints as well, whether that be clinical response, endoscopic improvement, or mucosal healing. We also have another agent in this class, etrasimod, for active ulcerative colitis, and this is an oral selective S1P receptor modulator. And when you look in the middle and the right panel, you'll see patients with endoscopic improvement at the 2 milligram dose. You'll see statistically significant difference as compared to placebo, and also for clinical remission, again, with that rate of about 33%. So we're seeing with all of these agents a similar rate, which is reassuring, but we're not yet at that point where we have a home run, where we've hit these numbers out of the park. I hope to be there at some point during my career in IBD. And David had mentioned that when you're talking about these S1P inhibitors, you do actually want to see a significant dose-dependent lymphocyte reduction because this is associated with efficacy of the agent, and we do see that here associated with etrasimod. So finally, let me just spend a few moments talking about clinical trial participation and wrapping up our case. I would like to emphasize that there are a huge number of clinical trials recruiting right now across the country. Our site and many others are participating. And unfortunately, there may not be enough patients to go around. On the right-hand side, if clinical trial participation does not increase, we really won't be able to get the answers to some of these questions. And so we did a study in our IBD partners cohort, which is an observational cohort of patients living with inflammatory bowel disease who fill out surveys over the internet in terms of how they're feeling and what medications they're on, whether they participate in a clinical trial. And the yellow line on this graph shows over the years clinical trial participation per year, which has actually come down over the past 8-10 years or so. And the blue bars represent number of randomized control trials available here in the US, which is going up. So we need to close that gap. One of the problems with closing that gap is that there are very selective inclusion criteria in clinical trials. This was some nice work done by one of my colleagues and friends, Christina Ha, who at the time was at Mount Sinai, that looked at patients with moderate to severe inflammatory bowel disease at their center and said, well, who would and who would not have fit the inclusion criteria for clinical trials? And only about 30% of patients would have been eligible, and they had a number of exclusion criteria, which mostly were associated with severe disease. And then when they looked to see, well, how did our patients do in practice, based on whether they would have been trial eligible or trial ineligible? And really, the trial ineligible patients did worse. And so, we're applying this data from a very select population to a broader population that may not quite be as accurate. So we really do need to learn more and try to include more patients in our clinical trials. From a patient's perspective, there are some barriers to participation, including time constraints, and they really do want to have their primary IBD provider involved. And so I would really encourage you, even if you don't do trials at your institution or at your practice, to work with someone who does, and then that way it would be a great outlet for your patients. Patients really want better communication. They do want lower placebo rates, which we're having now. We're doing more comparative studies, and open label extensions, meaning that they're guaranteed access to the therapy. Those are the sorts of things that have really helped us with participation over the last decade or so. So really, who should be included? Patients with a definitive diagnosis of IBD and a disease duration of at least 3 months. They should have objective evidence of active inflammation. Someone with a short fibrotic stricture is not a good candidate for a therapy with active anti-inflammatory properties. And they should have the possibility for improvement. And trials participation really should be offered as an option to appropriate patients to allow for more diverse recruitment and to improve outcomes for patients. And really, in our cohort, things that was like aggressive disease, biologic exposures, and lack of steroid-free remission that were associated with clinical trial participation. But there may be opportunities earlier for patients who could benefit from these trials. And so really, we should be thinking about it in everyone. So let me just go back to my case. I did offer him participation in a clinical trial, and he chose a novel adhesion molecule within a 14-week induction period where he had a 3 out of 4 chance of getting active drug, but he had to stay on prednisone during that whole time. So he had a lot of side effects and unfortunately did not have a response. He really had Mayo 3 score on his endoscopy. But he rolled into the open label extension. He was guaranteed access to the drug, and he really had dramatic improvement and did well. And he'll get to stay on this therapy for over 7 years in an open label extension. And the patient, in spite of having a delay until he improved, he really enjoyed his clinical trial experience. I'd like to summarize that vedolizumab has demonstrated excellent efficacy in real-world populations and excellent safety. There's no current role for the use of natalizumab in IBD, in my opinion, except in unique scenarios that are likely with concomitant MS because of safety issues. There are a number of promising anti-integrin therapies under investigation. And I think the Etrolizumab results are somewhat puzzling. They did not meet their primary endpoints in UC. But there are a number of other promising anti-integrins with phase 2 and ongoing phase 3 data. And S1P receptor agents are under investigation and actually have reassuring safety and efficacy thus far. The phase 3 trials for UC with ozanimod were positive, and etrasimod also with promising phase 2 data. Remember that clinical trials participation can help to move the field forward, present this as an option to patients earlier in their disease course, and that available mechanisms for UC and Crohn's disease will continue to grow over the next decade. So with that, I thank you, and I'll turn it back over to David.
Millie, that was amazing. You had a lot of heavy lifting to do to present all that data, but you did it in a beautiful fashion and summarized it terrifically. Okay, well, with that, I want to thank you, Millie. Always outstanding, and I really enjoyed the program with you today.